We are on a mission.
A mission to save and revitalize independent pharmacy.
On the Catalyst Pharmacy podcast,
You will get actionable business advice
hear stories from industry leaders,
and share a laugh with us.
fuel your passion for pharmacy.
One conversation at a time. Hello, Shawn.
What's up, guys? Thanks for having me.
Hello, and how are you?
Living the dream, buddy, aren't we all?
I see. I'm already digging your art game there. I like the colors. It reminds me of your stuff in your Spaceman.
Yeah, the painting in my office.
It's a very popular way of kind of, if you're watching, Kelly and I are watching The Voice, and they have the pictures of the judges are done that way, that kind of colorized.
But if you don't know the Big Lebowski, I don't know that we can continue to proceed. I don't know if I can proceed if you don't know who the dude is.
Okay, I know Jeff Bridges, Big Lebowski. Yes.
So I did not like that movie. I'm just one of the weird people.
Now he can't proceed.
I'm just saying, I didn't.
You just lost a point.
It was in the same year as Sylvester Stallone did Raw Deal. I don't know.
You probably didn't smoke enough marijuana.
Yeah, I was just saying I was not in the wrong state of mind
to watch the movie. Otherwise, there's no value in it.
So who's the hair, the eye and the hair?
So the hair was just the interesting picture of the interesting story behind that is I was in with my wife in New Orleans for a Mardi Gras, and we walked past the studio.
Okay.
And I was like, man, that is sweet. So
nice.
I bought it down there, and then we had it shipped home so it wouldn't get damaged in shipping or whatever. But the lady who does it calls it "Mornings on Fire" is the name of the picture.
I like it.
The gist of the artist was there selling it, like at her booth.
Yeah. And
she said, do you ever wake up on a Monday morning and this is what you feel like? Yep. And I said yes, and sold.
Yeah.
I love it.
That's kind of the story there.
My hair is on
I
fire.
love walking around the French Quarter and just the art. And
what was she on Jackson Square, or was she actually in a store?
I'll show you one more just to be good. Can you see that angle over there?
And
but
it's Johnny Depp and
it's Fear and Loathing in Las Vegas.
Yep.
Which is another, weird movie to watch, but there's, it's entertaining if you can follow it.
Yes.
So Jeff Key, president of PioneerX. I'm not positive we've met.
I don't think we have,
the
Jeff.
CCO of Red Sail, and Marsha Bivins.
Hello, I'm Marsha Bivins. I'm Director of
Hi,
Trade
Marsha.
Shows and Events for PioneerX.
Awesome. Well, we're Pioneer fans here at ACORx. We switched probably 2 years ago or so, and, we haven't looked back since.
Nice.
Awesome.
Lots of exciting things to talk about, Shawn. He's the owner and pharmacist at ACORx.
Pharmacist might be a stretch, Jeff, but, don't ask me about side effects or clinical thoughts. You want to talk about the Big Lebowski? I can do that. You want to talk about how gabapentin interacts with diazepam? I'm not your guy.
You're not? Okay. How about, I heard you're a concert guy. Tell us about that.
I do. So the guys flipped when I told them this, but my wife and I are going out in December 1st to the Sphere.
Nice.
It's awesome.
Did you go see U2? Yeah.
Yeah, so U2, they're kind of the resident, they're kind of the house band there for the time being, it seems.
We did not see U2 there. We saw their
it was
postcards from the edge, or letters from the edge.
Letters from the earth.
Postcards from the earth, maybe?
I don't know. It was interesting.
I didn't even know they did that. I thought they were just, so was that prior to them starting?
So they're not there every night.
Okay.
So on nights they're not there, they do this postcards from the edge. It's billed as 2 hours, but an hour is pre-staging you, telling you there are things to watch. There's some robots and there's some things that show off technology.
There's a bunch of stuff in the lobby that kind of walks you through, how they've managed some of the lighting techniques and the sound, and you get to kind of walk around and experience these robots and other really cool things, and it's really interesting. It's really cool.
Yeah, where are you? You're in Pittsburgh.
I am. Your buddy Craig's right up the street from me.
Yeah? Does he ever come see you?
Yeah. He came originally, and now he doesn't come anymore. I think I yell at him too much.
Do you yell at
No,
Craig?
he's a great guy. I mean, I think he's pretty savvy. I appreciate everything he brings to the table as far as, his knowledge and his, interesting background. And
so you think about Pennsylvania and you think about a blue collar history, you think about steel industry and all that kind of stuff. But it's amazing how often I run into really progressive things coming out of Pennsylvania. That's one of the biggest flip the pharmacy states, very true. Very busy in CPSN. And then I'm all kinds of times here in startups that are in Pennsylvania. So what did that, do you think that was just kind of a purposeful transition?
So I'm actually on the PPCN board of directors because I believe in the CPESN, the clinical aspect of pharmacy. That's part of the reason drove us to Pioneer, right? Your position in that space. So, ACORx is very involved in that. But to answer your question, don't forget we have 2 pharmacy schools right here in Pittsburgh, number 1.
Right.
So that explains a lot of the pharmacist or the pharmacy industry, opportunities in Western Pennsylvania. But then from the true, like just the, we have, everybody is here. Google's here, Microsoft is here, Facebook is here because we have Carnegie Mellon University and that they all want to hire people coming out of Carnegie Mellon.
Okay.
Interesting.
So that's a huge, so we truly are. I mean, it's like, from a tech standpoint, we are a tech haven. We're much more tech now than we are Steel City, blue collar. That's right. That's days of old. So, 70s, early 80s, it was blue collar, even before that. But, then for my generation or my age at 54, the 70s was steel or football, steel mills.
So during the pandemic, a lot of people moved from California or they relocated. Did you see a lot of people move from California out of Tech Valley to Pittsburgh?
Yeah, that would be rough because there's just not a lot of sunshine.
That would be a serious adjustment.
You got to get used to gray.
Jeff is right. We don't have the weather to attract those people.
Yeah.
We have the schools, but once you're
that's what I meant. I mean, the schools would be, if the schools are attracting that much business.
It's just the weather. That'd be a hard move from California.
No, the schools, they do come for the schools, but so then obviously some people stay here and work because Google's here. They're all here. There's not one big tech company that's not here in some capacity.
Well, Shawn, tell us a little bit about your history. Tell us how you got to ACORx and kind of what you've been doing before.
You're not a pharmacist, but you have
I am a pharmacist. Okay. I'm just not a good one.
Okay. We can edit that out.
I'll give you the long story and I'll shorten it as best I can.
Okay.
All right.
We have an hour to fill. I mean, if you need me to keep talking, just say so. I can talk with the best of them.
That's awesome.
So I chose pharmacy growing up because when I grew up in a small town just outside of Pittsburgh, I grew up in Ford City. I don't know. Do you guys know, Klingensmith's Pharmacy? Does that ring a bell to you?
It does ring a bell, actually. Yep. So
Klingensmiths, they're pioneer guys too. In fact, when we switched, we were very involved with them. So I grew up there, and my father was best friends with the pharmacist in town. And, Dave will laugh if he hears this show, but I was, they were always the ones with the nice pool. They had the nice cars. They were going on vacation. I was like, man, I want to be a pharmacist.
Yep.
So fast forward, my family moves out of the rural up there to downtown, to Pittsburgh proper. Live down there. I go to school. Unfortunately, my father passes away at some point in there, and I'm getting ready. I go to pharmacy school because I was literally zeroed in on pharmacy from my growing up up there.
It comes with the pool and a car.
It's all about the money,
being around the Klingensmiths empire, right? Yep. So I go to pharmacy school. I get a job with Thrift Drug, which was sort of the precursor. Today, they're probably Rite Aid. If you follow Thrift Drug, and then Eckert Pharmacy bought them, and then Rite Aid bought it. So, it's probably a Rite Aid predecessor, Thrift Drug. Couldn't stand it. I mean, it was, again, it was the same reason that they're having all those walkouts today. It was no different 30 years ago. I mean, the same conditions applied. Maybe not quite as bad because there weren't as many drugs. Drugs weren't as expensive. But I said, so I went to my mom. I said, Mom, I think this job stinks. I should buy my own store and work that angle. And my mom says, well, why don't you go up and talk to your friends, your dad's friends in Ford City? I said, okay, I'll do that. So I go up there, and Joe, who's the sort of the patriarch of the family, was my dad's real good friend and shows me around, right? And now, when I left, they had one store in the middle of town. Now he has like 7 stores. They had a long-term care pharmacy. They had a DME business. I'm like, this is really sweet. So he brings me into his office. I said, Joe, I'm thinking about starting my own store. And he kind of looked at me and basically he said, long story short, he said, hey, man, your dad was a good friend of mine. Let me help you. He said, I will buy the store. You will work the store. We will be partners and go find a store. I was like, well, I'll take advantage of that.
Mm-hmm.
So gratefully, I mean, the Kling & Smith's family, Joe, and then Dave, who's the son now that runs all their stores, that's why I got started. So we had my very first store, and then from there have been various iterations of business. At one point, we had 8 or 9 retail stores that were located within grocery stores. We had a long-term care pharmacy, and as some of those partners got older, Joe kind of retired, and then Joe passed away, and we've had various iterations of our businesses. But a few years back, I was sort of I don't want to say the sole survivor, but I was sort of the last active person of the original team that I had 2 retail stores and ACORx pharmacy. I'll give you the ACORx stories separately. Okay. So I had 2 retail stores, kind of saw the writing on the wall that retail was, struggling. And I don't know, I still am not necessarily confident in like independent pharmacy survival, at least in its current state, right? I don't know that the model is mid-morph right now. It's morphing as we're speaking, where the opportunities are. But that's when I created, out of that, I created ACORx because I just was lucky enough to kind of see that people living at home, how valuable that is. The future. I mean, Western Pennsylvania is one of the oldest spots in the country.
Okay.
To this day, it's still one of the oldest counties.
Yeah.
We could build a nursing home every day here, and we probably won't have enough like beds, so to speak, for the population as they age. And then you marry that with how expensive it is to be in a nursing home.
Yeah, and you want to try
marry
to
that
be.
with people not loving. Nobody wants to go to a nursing home. As you age. So we kind of embraced the aging at home market, and that has been really beneficial for us here at ACORx. Of course, it's my team that drives the bus. I mean, I sit in my office and talk to guys like you. I just the best thing that I do is hire smart people.
Yep. Yeah, I think
that's the
just
history.
Just to hit the independent pharmacy or community pharmacy, a lot of things are really looking positive for that in the next year. So I think I wouldn't give up hope on them yet. One of the only things that our federal government agrees on right now is PBM reform. So
listen, I'm all about that, man. I'm a big backer. I do a lot of legislative stuff. I know all of my legislators. I encourage my team to know who their legislators are and to make sure that they're supporting our cause. I'm not saying it won't exist, but it's just going to be different, right? I mean, the morphing has already started where if the guy just thinks he's going to stand behind the counter, fill prescriptions, and talk to the people when they come in all day, that recipe does no longer work.
Right. Yeah.
No,
I agree. Yes, we got to move to more clinical and spread services and figure out what we're going to do as drugs get cheaper and cheaper. But with transparency, one of the things coming out of NCPA and talking to people we're finding is that, we used to think, well, independents just aren't efficient, right? Single stores, they're not efficient. They can't be efficient enough to compete with the big guys. What we're finding is that the big guys are getting paid way more per script than the independents are. We saw specific examples, independents getting paid $5 and CVS getting paid $15 on the same drug, same plan, And the patient has a copay of $0 at CVS and a copay of $3 at the pharmacy. So the guy who's really not efficient is CVS. CVS isn't efficient. They're pulling too much. They're making 3 times what the independent's making per script, and they can't even properly staff their stores. If that came to the middle, right? If you just took those two and averaged it and gave everybody that middle price, CVS would get out of pharmacy, and the independents would be thriving. So, there are a lot of interesting things out there that are with transparency that are being debunked. But this is kind of a side note.
Yeah, as we get really smart guys like Mark. Gosh, I'm blanking on his last name right now. His podcast was a couple episodes ago, but I mean, he's working with multiple states and thousands of pharmacies on the.
Oh, you're talking about the lawyer?
Yes, Mark Cooker.
The lawyer.
Yes, the
All right,
lawyer.
so
There in
does
Pennsylvania.
anybody like lawyers? I mean, tell me the truth. Does
Yeah.
anybody really like lawyers?
No, I don't know. We
This
started off with a
one-
good lawyer joke on that one. So.
Yeah.
I don't even know Mark, but good for him for helping the cause.
Well, you're
I mean,
actually seeing, I talked to a pharmacist this morning who's headed to a focus group.
ESI, the
independence.
ESI thing.
Yeah, put on.
Yeah, I got a lot of friends up
just-
there. Somehow,
just right
Stephanie,
down-
who's
it's in
running that,
Boston.
Stephanie
Yeah.
Smith-Cooney, who's running that, is from
Okay.
this area.
Yeah. So we don't have so you're wondering what's going on. One move for PBMs is to say, hey, I'd rather make friends with this group than have government regulation. Right. So we'll see.
Is it an olive branch? I mean, I don't expect anything to come out of it because as reimbursements move, again, if we get to a NADAC plus model, we can all survive, and that's probably the coup de grace of where independents want it to go because you're just guaranteed to make the money. You know what you're going to make, and at that point, it's up to you to be good with the money that you make. It's up to you to be good to grow your business. It's up to be good for you to manage your business, and there will be some shakeout in that because not everybody will be good at it. But at least you know where you stand versus the hit or miss. But so that is certainly an opportunity there. But they're just vicious. The PBMs. I don't think that's going to happen overnight. Even though
Right.
we certainly have more momentum than we've ever had. You're going to have to survive for 5 years before you might see something like that truly, move the needle.
Well, and that's what,
Performance.
PBMs moved from if I can be big enough, I can save my customers a lot of money to if I can be big enough, I can make a lot of money. Right.
Yeah. I mean, they are. But listen, I'll be honest. I wish I invented them, right? Or I wish I owned one. I mean, because they're successful. And that's what motivates me as being a successful business. I don't want underhandedness, and I don't appreciate non-transparency and all, of course. But, you can't argue that they found their niche. They found their niche. I mean, I think that, again, there is a happy medium, though, like Jeff, you were saying. I mean, kind of, halfway through the, if we get, there's a way for everybody to get paid and everybody succeed. And at the end of the day, to keep patients healthy, which is, which is the ultimate goal. I mean, Rite Aid's bankrupt. They're throwing the opioid thing under the bus, but let's be honest, they took contracts for a long time.
Yeah.
Yeah. And so don't act like it's the opioid thing that we're supposed to feel bad for you. You mismanaged your stores for a long time. You've been probably threatening bankruptcy for many over the years. And, you can't keep taking these bottom of the barrel contracts for a matter with the event of Amazon. Nobody's going to those stores to buy the deodorant and the shampoo and the pop and the food and stuff that they thought they were going to capture. Or they probably did capture in the late 90s, early 2000s. But now people shop different. So having a 10,000 square foot massive store on the corner, nobody's really going there. So, but there will be shakeups, constantly. I think that's part of any business industry, right? It always evolves. That's just a business fact.
And when you look, you got two things from that. Chaos is where smart people make money. Period.
I just said that to somebody else. Not exactly, but I said there is going to be so much opportunity in this fallout. We have to figure out what exactly it is, though, right? I mean, it's anybody's guess where the needle lands.
And I love Troy Trigstad always says, if you don't like your hand, flip the table. You know,
Troy, I'll tell you what, he's one of the smartest guys I know. I always enjoy. He's coming to Pittsburgh next week, and we have lunch. We're having lunch together.
Interesting. All right, so your game, ACORx, is the kind of the pharmacy at home, the long-term care at home model.
That's the space we play in. So we're closed door. We have LTC contracts through MHA. You guys know Lindsay Demowski. I think she's been on your show before, right?
Yeah, she was recently on.
She's in Eastern Pennsylvania. I'm in Western Pennsylvania.
Okay.
And we're kind of moving in parallel, in parallel ideas of the opportunity. I mean, I think pharmacy, with the fact that we're under such pressure now for primary care doctors, for example, right?
Yep.
Somehow pharmacy has to put itself out in front of that, right? Maybe we become the gatekeepers. Maybe we become the initial point for people to see. Now you got to pay me for that. You can't come in and let me do nothing, right? But if I could get prescriptive authority for a Z-Pack, I could save a health plan tons of money.
So
right? I mean,
my opinion is doctors should be diagnosing and pharmacists should be prescribing.
Yeah, I mean
that's not going to happen, but
viable, but that's an extreme. I mean, that's pretty.
Yeah,
that's it. I'm asking for Z-Packs. You're asking for everything.
But that's no. You start with an extreme. You're like, I want 80% raise and only want to work 4 days a week, right? So you can get the 23% you want. So,
well, I think the biggest.
Hey, I should send you to Detroit, and you could negotiate for the auto workers.
About what he did.
But no, I agree. I'd rather walk into a pharmacy and go, hey, flu test, give me Tamiflu, not go sit in a doctor's office where I think I've got a cold symptom and I end up with flu because I'm sitting next to 10 other people who have the flu. Yeah. So,
or just poison ivy, right? I can give you a dose pack. I mean, I can ask you the appropriate questions to do that. Mm-hmm. And now the doctor doesn't have to waste his time with the sort of trivial things. But, the other part, listen, doctors are always barriers. I don't know if they're threatened by us, but like the AMA, they fight everything that pharmacy tries to do.
Yeah.
I'm surprised they let us do COVID shots because they just fight everything that we try to do.
Yeah.
Yeah, and that's understandable. You're always in an industry, and you're in an industry as a doctor who the next year is never better than the previous year, right? They crank the screws down on Medicaid. They crank the screws down on Medicare. You're deciding this year, am I going to take it or not? The health systems are screwing you down, and now you got people on the other side. The pharmacists are trying to take some of your visits. So it's just a reaction to everybody's a multi-front war.
What do you guys think about the walkouts? Like, I haven't heard. Like, what happened with the whole Pharmageddon thing? Like the last day or two? Did they get some momentum?
I guess I don't know either. It's a 3-day deal.
I haven't seen anything
We're in the middle of
it.
This will be day 2,
See,
right?
I'm wondering, that's an opportunity for pharmacists who we keep telling them, that was part of Jeff's speech, was get out of your pharmacy. Hire another pharmacist that allows you to go out and kind of be like you, make the smart business decisions, drum up more business while somebody else is behind the counter for you. And so I think that's an opportunity if you're a pharmacy in those areas where the walkouts happen.
I'd certainly be trying to do some type of marketing deal saying our pharmacists are happy.
Yep.
For sure.
Pharmacy.
Don't you want to be someplace where not only do we love our employees, but we love our customers too.
Or an opportunity for a pharmacist who wants to retire and hire one of the walkouts and make a succession plan going, hey, here's how we're going to do this. Here's the plan.
You would think that, but listen, as a business owner, an independent pharmacist owner, when I need a pharmacist, those guys just don't come because they're afraid. They're comfortable maybe. Like, it's like, I know what I'm getting over here. I think you're going to go out of business in 2 years, so I'm not going to come to work for you. It's not as easy as Jeff, like you were just saying. There's a disconnect between those people not liking their jobs, but their willingness to jump into an independent.
Yeah, they're thinking they don't have good benefits, or they're thinking,
Yeah, probably not enough benefits.
It's a comfort level.
They hear a lot in the industry of us complaining that, CVS is taking $10 from me, and they're giving you $50 for the same drug. So I could see where there's some a little shakiness of not wanting to.
Were there walkouts in Pennsylvania?
Not directly. Like, I didn't see any coverage. I mean, I know there was some scuttlebutt about them potentially, doing it. And I had heard that one of the chains sent out letters saying, if you do this, you're fired. And, who knows if that happened, but I just haven't heard. Unfortunately, I don't think it maybe is going to pack the momentum that we want. Or for all I know, PBMs went to the media or the chain stores went to the media and said, don't cover this.
Yeah.
I don't want you covering this. I advertise on your, Walgreens advertises on all of your networks. Don't cover this because we don't want it out there. It's bad press for us. I don't know that. I mean,
NBC reported 900 people in 10 states, but it's difficult to verify exactly.
Yeah.
So, but it is set to end today.
It's pharmacists' fault. I mean, we put ourselves in this spot, years ago. Even the independents taking the bad contracts and not, there has been some pushback. I think some guys aren't taking the new ESI deal, because it's kind of inclusive of the DIR. They put the DIR into the reimbursement,
right, which is what everybody has to do. Yep.
Yes, but it's the number doesn't work. I mean, you're going to lose money on every single prescription based on the math that they're providing.
Right.
So why would you sign up? On one hand, on the other hand, you want the patients, you want the opportunities, but that is an old-fashioned way of thinking too.
Right.
Right. Everybody used to say, we want the people, so I'm going to take it. I'll figure out how to make money later. It's not.
Well, you got to figure out how to, if you're going to do that, you got to figure out how to make it. I think a lot of people taking it just don't know.
What going back to Troy, he's really onto something with CPESN. I mean, there's tons of momentum there. My partners and I a couple of us just started another company that we've launched that is a clinical provider. So we will go to a store in the network and say, if you don't have the manpower to do your clinical engagements, we'll send our person in there. Sure, we have to kind of, we want to make money and we want you to make money, but if you're not going to do your clinical engagements at all,
right,
and I can make you $3,000 or $4,000 and you don't have to do anything, then hey, let's do that. And I think that's a fair space for us to play in. We just started. It's called Architect Health. I'll have you when we kick it off. I'll come back on and we'll we'll talk about that.
So is that physically sending somebody? So you're like, I'm gonna have somebody in your pharmacy once a week?
No, it's physical. Yeah, because you can't do a lot of that stuff remote. The contracts don't even allow a remote model in most cases. Like outcomes, they don't allow remote. They want it done in the store, which is, I mean, again, I can live with that. But we're building it around that model where we physically send somebody to the stores.
Is that a pharmacist? Are you sending a tech? Are you sending a nurse?
Depending upon the opportunity. Some opportunities require a pharmacist. Some really don't. Some of it is just billing for services that the pharmacy provides. We have one of the HMOs in town here, and Pennsylvania is like one of the top performers in the CPESN network.
Right.
Our network
I believe
is called PPCN, the Pennsylvania Pharmacist Care Network. But Brandon and Stephanie over there are doing a tremendous job getting us opportunities. So we have an opportunity for, essentially what I do. I'm now finally getting paid for what I do. MedSync, MedPack, and home delivery. One of the HMOs is bundling that service, and we're able to bill them through the PPCN contract.
Oh wow!
So it's there's opportunity there, and if we can make that perform, then again, the unknown is the health plan going to care? Right. Are they getting a return on what we're doing?
Yep.
And that's what's hard for us to quantify because we don't see the statistics. We don't see everything. Everything in healthcare is siloed. But pharmacies over here and medical's over here. I have a medical doctor. She loves us, but she jokingly beats us up all the time because her medication costs go up.
Right.
She has a bunch of asthma. She has a bunch of asthma people. They're all on these inhalers that are $1,000 a month. And she's like, oh my God, my drug costs are spiraling out of control. Her bosses are up her ass. But in the meantime, I'm like, well, ask them to see the medical side. Because if we stop, 5 of these people from going to the ER when they have an exacerbation, then we've already saved your money that you're seeing on your drug cost increase. But they don't think that way.
Yeah, they got to think that way. It's just like,
By
I
the
think
way, let me tell you this, Jeff.
Good.
1 second. I'm sorry. I told you I talk a lot, man.
Oh, you're good.
I just got a lot to say. But that's how ACORx came about. Actually, I created ACORx in the back of a pharmacy meeting with a couple buddies, but they were talking about ACOs, accountable care organizations.
Yep.
Which never really took off like maybe they thought. But it's ACORx because I thought my vision was to become the sort of pharmacy clinical piece of the ACOs. Now it turns out many of the ACOs, they really don't. They engage pharmacists for the knowledge, but they don't really, most of them don't get into the dispensing side.
Okay.
Which leaves a gap there, but we tried to fill it and, nobody's listening today. But that's it's ACORx was the original. We now say ACORx, with a silent X.
Yeah.
But that's how that was created because we said, hey, man, the ACO concept is great. It's everybody under one umbrella sharing information to maximize the patient. So the doctor knows what the pharmacy's doing, knows what the specialists are doing, knows what the home care agency's doing. Where, traditionally, that doesn't happen. Even to this day, that hardly happens.
Yeah. Well, a lot of, CPSN has helped push a lot of that, helped educate a lot in the in the health plans and a lot of trying to bring that together. Just had a great paper come out that Idaho CPSN reduced hospitalizations by like 30%.
Wow. That's great that they have access to that data.
Yeah. Compared to non. And, Idaho's a pretty progressive, but that'll progress through, right? Idaho will do that. Pennsylvania will try to do the same thing, and other states will start replicating that. It just, change is slow.
Yeah, but how do you get other states to jump on board with that same type of mentality with, hey, these are the things that we're doing in our pharmacy for your patients, and we can help improve? Well,
you show them the study in Idaho, and you say, what would it mean to you if you reduced hospitalization by 30%? What's that dollars? Was it worth an experiment to carve out 5% of that and do something?
I'll tell you one thing that I had issues with, though not issues with, but always amazed me. When you talk to a health plan, it's a different language they speak. Like they're, and this is probably true for most health plans. The ultimate end goal of patients getting better or patients being healthy is third or fourth on their list. In fairness, to some extent, it has to be. You can't put everybody on a $10,000 specialty drug, that may have a disease state that's a benefit. Otherwise, they're not going to stay in business either.
Right.
So, but they balance. It's we want to look good, and we need to make money so we can survive, and then we want to look good in the eyes of the plan members because we want them to choose us every year and we want them to keep choosing us. And then we want them to get healthy. So there's this, they want to hit their HEDIS measures, star ratings and all like that supersedes a patient outcome. But to some extent it has to. Again, there's not there's not just a limitless fund of money to keep us healthy. We probably do have to get to a point where we start being proactive instead of reactive, right? It's cheaper for me to keep you healthy than it is for me to treat you when you're sick. But that also hasn't really, that mentality hasn't morphed into a functioning model either.
Right. Yeah, trying to figure out that model and how you measure it and how you prove it. It's hard to prove something didn't happen. Right? Well, you would have died of a heart attack. You would have died of a heart attack.
That's true. That's a good way to put it.
It's very hard to prove. Without some kind of, it's just hard to prove. Yeah, and the control group isn't very nice, It's not very saying you're in the.
No, you're right, and that's what they told us.
We're just
right,
not
that's what they told us. I think we need to get to a spot. Again, my goal, anyways, to jump back into an ACORx discussion for a minute, is we want to treat I want to get a per member per month from a health plan, and for that fee, I am going to provide the basic pharmacy services to begin with, right? Medication synchronization. We use we use the bubble cards here, not the pouches, but we use the VBM Omnicells.
Okay.
Global Factories has a VBM, so we use a multi-dose blister card for our packaging system. But so we're going to do all that, and then we're going to do these clinical engagements. If they're diabetics, we're going to educate them. If they're asthmatics, we're going to educate them. social determinants of health and the lower income thing, right? That's a new buzzword. I never even heard the term social determinants of health 5 years ago. Yep. Now every article addresses the fact that social determinants of health is an issue. Yep. Never heard of the acronym before in my life. Now it's front and center with treating some of these people. And I get that, right? Because that's the 20% of the population that cost 80% of the dollars. So, I want to embrace that and figure that out, right? What do I have to offer these people in order to keep them healthier? So then the health plan will turn around and say, hey man, we'll give you a per member per month. I'll give you $50 every month. Mm-hmm. You manage my 1,000 patients that you have under my, in our network that are your customers.
So do you have anybody that you're charging per member per month today?
We do not. We do not. We have the CPSN and PPCN plans that are paying us for some of those services that we would put into the bundle, but we don't have anybody. We've been at the table. They're just not there yet. I mean, I think they'll get there.
So I didn't necessarily mean a health plan. So here's what's interesting, right? I want you to pay me for something that I'm doing for free today that nobody else pays for.
I know. I've been yelled at before. You
got, you take Blueberry Pharmacy and these non-third party models where they have a subscription model where I charge a monthly fee. It's cash today, or it's part of, it's part of concierge medicine, right? So you're partnering with a concierge doctor and say, hey, concierge doctor, instead of charging $70 a month, charge $100 a month and bundle in pharmacy services.
Sure.
So if we can find places that aren't health plans where we can get paid a per member per month, then it's a lot easier to sell to say, I have this product over here that other people are buying, right?
Preferred pharmacies, right? If I can't I lose or don't get patients because when they come here and find out that their copays are $20 instead of $0 at a preferred pharmacy, they're not going to come here. We're talking about somebody that's on a fixed income. That's why we've kind of gravitated to, the Medicare, Medicaid, dual eligible space. Those people they need the most help. They have the least money. And
we need to keep screaming that preferred pharmacy isn't necessarily getting paid less.
Right.
That preferred pharmacy could be getting paid more. And part of their contract says, not only are you going to pay us more, you're going to give the patients a low copay.
Right. And it's
how crazy
is that? I can't compete with that. When somebody on my average patient's on like 10 medications. I mean, so if you're talking $200 versus 20 or 30, they're going to go to the preferred pharmacy. We need to work through that. But in the meantime, we focus on the dual eligible population.
So in that long-term care at home, is there an opportunity to charge them the person for extra services outside of the plan?
I mean, there is, but finding the population that's willing to pay is hard. And you're right, man. And listen, I sometimes, kick my own because I'm like, you're doing this for free and then you're asking to get paid for it.
Yeah.
But it's kind of a chicken or the egg thing. Like I got to show some results. I got to get some patients and I got to show some results.
Yeah.
Or knowing who's really going to care in the first place.
So my wife's family, not long care at home necessarily, but my wife's family's parents are in assisted living.
Okay.
That facility has a preferred pharmacy. It's a closed door pharmacy doing their scripts, and they're just doing whatever the doctor says. They're not thinking about it. They're not thinking about interactions. They're not thinking about what time of day they should take it. My wife would pay, if there was somebody in that town that charged $30 a month to properly analyze that medication, she would pay for it.
Or what we've seen here is in that instance, most of those, like those assisted living facilities, they can kind of push you to a pharmacy, but they're not necessarily allowed to steer you or make it mandatory. But then what they do to get around that is they charge you $30 a month if you're going to use another pharmacy.
Right. Yeah, because they're getting some kind of
cut.
cut.
And so someone's like, I can't do. I'm just going to use the one you have because it's easier.
And the other pharmacy may be just as bad. What she needs is, one of these consulting pharmacies or somebody who has an extra service that actually does something with the medications. Because, doctors, her father was on dialysis and got off of it, and there's a medication associated with that my wife thinks he should get off of. And the doctor was like, well, nobody ever gets off of that drug. How many people get off of dialysis? Yeah. Not very many. So the doctor just doesn't really have a clue about the drug and how it works and how it interacts with the other stuff. And you really need, she really needs somebody with a PhD in pharmacy who's looking at that. So to me, now her parents don't know that, but the caregiver knows it, and so I think in that scenario, that's why I think about long-term care at home. A lot of those people have caregivers, right? Or have family or have.
That's how we grow our business, right? Because I go to the home care nurses and say, hey, when you have a patient that's upside down in their meds or doesn't have a family member that's going over there every Sunday to fill their pill box for them, I'll deliver the pill box, right? And that's what I want to do, is what you're saying, is manage the patients. We'll deprescribe if we have to, right? The deprescribing is a relatively big thing too. It's an aggressive approach, but it certainly should happen because most people are over-medicated, specifically in facilities.
Well, there's deprescribing. There's, one of the things we've learned from some stuff that Tabula Rosa was doing and things like that is that some drugs shouldn't be taken together. They can be taken. I can take both of these drugs, but I really shouldn't. If both of these are twice a day, I really shouldn't take them both at 8 o'clock. I should take this one at 8 and this one at 11 because they use the same pathways. There's just, I think there are opportunities. You're selling the opportunity to get the business and give it away for free, right? You're saying we're going to do this analysis for you, and you're going to give us your business.
Well, what I like now too, you're getting into, like you just mentioned, like the pharmacogenomic thing. I would like to run all of my new patients. I would like to make that part of the process, but they're not going to pay me $400. To do to initially do that, so I can manage their medications and tell the doctor, you should probably be on, you metabolize simvastatin faster than anybody else. You should be on 80 milligrams instead of 40.
23andMe just added pharmacogenomics testing to their little kits, but it's still a membership basis where it's you have to pay to get the additional results. Like they'll tell you some basic stuff, but like if you sign up for it, they'll give you the pharmacogenomics testing piece of the DNA kit.
Do you not get anybody to pay for the pharmacogenomic test?
So we haven't pushed it because, again, our business on its own has shifted in the past couple of years to that low-income, dual-eligible Medicaid space. So I do lobby the health plans to say, why aren't you paying for this? There's value in me dosing this person accordingly. And mental health, pharmacogenomic testing has spectacular results in mental health patients. Yeah. But I think they're afraid to open the floodgates because all of a sudden they're going to have 10 million pharmacogenomic tests coming through right away.
I bet you that pharmacy that they're using today for my wife's parents would take a per payment month fee. And try to claim that they're doing what they're supposed to be doing today. You know what I'm saying? That's your challenge because everybody starts getting money and they're not doing it. They're not doing what they're supposed to be doing with
That's right. Everybody's throwing a pharmacogenomic test in with everybody so they can capture the $400 or $250, whatever it is. Right. But there's value in it. But again, what I was going to say is I would take that pharmacogenomic test. I would take my per member per month fee of $50. And I would still give them that pharmacogenomic test because by month 6, I'm getting my money back for that pharmacogenomic test. Right. But a $50 per fee. But if you include that test on the front end, maybe there's some incentive or maybe someone will care.
Yeah.
As drugs get cheaper and cheaper, we're just going to have to. We're going to have to start getting paid for the services separately. And
especially when you have a patient come in and say, an opportunity to offer up a pharmacogenomics test is kind of a success story in a way. Getting prescribed a medication and then coming back and going, it's not working. Like it works for 30 minutes and then it's like it's not working. And then I found out that there was a prescription that I was given and it worked for the first 30 minutes, but then it was like it wasn't working and everything on the test said I was a rapid metabolizer. Right. And so that if I would have gone to the doctor rather than doing that test, then the doctor would have said, well, let's increase your dosage.
Yeah, well, one big problem that we did not address at all here is pharma itself, because I think if COVID did anything for me, it showed me the power of pharma.
Right.
Pharma said we need a vaccine, we got a vaccine. Pharma said we need a booster, now we need a booster. Pharma said we need another booster, now we got another booster.
Right.
We're ruling that out. Jeff had a good point a couple minutes ago. Drugs are super inexpensive nowadays, but what the is everybody bitching about on the news? The cost of drugs is outrageous.
Because
It's not.
because the PBMs
It's not.
are record profits in a time nobody else is making any money.
It is not. The price of I can treat anything for $10.
Yeah.
You know, is it the best, the newest, the latest? Maybe not, but I can treat it. And if you take it, you know, when you're supposed to, and if you kind of put a little bit of effort, we also have to empower patients. We're in a world where patients want to take it, right? They want the Wegovy to lose weight. That's great. I think it works. It's great. But you know, you got to do your part. It's not a miracle here. The same with drugs. You got to take them. You can't just, you know, buy them and put them on your counter and take them one day and don't take them the next because you're, you know, I yell at my mom all the time. She said, oh, my blood pressure's fine. I didn't take my pill. I said, what? So, you know, that's another issue.
Had a guy reach out to me, a pharmacist who I consider reasonably negative. He actually reached out to me to tell me how much he appreciated me. So I think he's working on that. He's working on gratitude. He's working on some daily gratitude. But I reached back to say how he was doing. He said, you know, we went to a generics-only pharmacy a few years ago and we're doing surprisingly well, right? And so, you know, not doing the brands, most things can be treated with generics, right? Most patients are on generics. The generics, once I'm going to generics, I'm not tied to a single wholesaler. I can buy well because I can buy all over the place.
And insurance isn't going to pay for most brands.
And a lot of times a patient who's buying, you say, hey, this generic is, your copay is $15, or I can sell it to you my cash price for $10 and I make more money. So it's super interesting.
Oh, you're the Kyle model right now. You're talking the Kyle model with Blueberry. I mean, Kyle is super. So, you know, they're right here in Pittsburgh. I mean, they're 2 minutes from me. But I mean, what Kyle, I love when he spins the concept of his pharmacy all the time. We just did a meeting at Duquesne a couple of weeks ago talking to students. And he said, think about this. When you have insurance, you have car insurance. Every time you get in a car accident, you don't necessarily turn in your fender bender because it's not really insurable. It's just cheaper if you pay it on your own.
Yeah, that's a good example.
So that's kind of the model that he uses. He's like, your oil changes are not insurable. Why doesn't your car owner, why doesn't insurance pay for your oil change? It's protecting the life of the car. But they don't, you know. So he said in medicine should be the same.
Yeah.
There should be no, you know, like, you know, there's a certain amount of dollars or a threshold. That's a deductible, right? It's the concept of the deductible.
And he's up to a couple of thousand patients per member per month.
Mm-hmm.
Yeah, he does well. Listen, everything is a per member. I'm waiting for Dunkin' Donut to be a per member per month so I can enjoy it. You know, but my car wash by my house is a per member per month. You know,
same by ours.
Of course, Kyle is. You know, you got your Sam's Clubs and stuff like that. I mean, everything is going to that.
Membership.
The gym. Every gym is per member per month now.
Mm-hmm.
Yep. Yeah, you don't
That's
pay
a new
for just
concept.
a single visit.
Yeah. Well, I mean, and like the thing on the other piece, like you mentioned gym membership, is they've even added a piece to it that's like, okay, you get access to the gym equipment, but if you want to get access to the pool, then it's this much per month.
Right, you have different tiers.
And you have to sign up for like a full year. You can't just sign up for, which I get what they're doing. They're just trying to prevent the people from signing up for just the summer, just to have pool access, even though they don't touch any of the gym equipment.
Yeah, a lot of first guy to pick up on that was the golf club, the country club.
Yeah,
having people sign up and cancel after 3 months. Like, no. Summer only is more than just 3 months
worth.
They put
the initiation on the front end now. So now you got to pony up the front end money to start.
Yep. Mm-hmm. Well, Shawn, this has been fun. I think we got 11:03. I think I could talk for 20 more minutes. And
he could definitely talk another hour. He already committed to that one.
So you'll have to let us know how the U2 concert is. Send us some video clips.
Oh yeah.
I will report back in. How about that?
I'm very interested. Do they use any of the 4D stuff? So in the U2 concert, do they shake your chair? Or do they?
Okay. I imagine a lot of people are
use the
standing
fans
during the U2 concert.
Do they blow any kind of stuff? But they could still shake I think standing maybe that the platform underneath you vibrated, or was
I
it?
don't know. Shawn,
Enjoy.
thank you so much for joining us.
Hopefully we get to meet one day in
sharing your
person.
art with us.
All right.
Send me the clip whenever you're ready.
All right, thanks.
All
I'll
right.
edit it. Send it to my people. I'll have my people call your people.
All right.
Fantastic. All right. Thank you.
All right, guys. Ciao.
Bye. Thank you for watching the Catalyst Pharmacy Podcast.
If you enjoyed today's episode, please like, subscribe, and follow us wherever you get your podcast.
Give us a 5-star rating on Apple Podcasts to help us reach more pharmacy professionals like you.